I'm Dan Collins with Mercy Medical Center in Baltimore, Maryland, and you're watching Medoscopy. Thank you for joining us for today's procedure. Our guests are Drs. Charles Park and Jon McIver of the Minimally Invasive Brain and Spine Center at Mercy. Drs. Park and McIver, you're both neurosurgeons. So when people say their jobs aren't exactly brain surgery, you really can't relate to that, can you? So I understand that humans have 86 billion neurons in the brain, woven together by 100 trillion connections or synapses. Now, what sort of confidence does it take, to delve into that when we hear that we really don't exactly understand everything that the brain does or understand it completely? How do you do that?
I think that the question is very important, right? Because a lot of people say, well, brain is so complicated. It's got trillions of connections. How do you deal with it? But during the past, I would say about 50, 60 years, there's been so much advances in medical sciences, especially imaging and operating techniques that allow us to actually look inside the brain, actually know what we're doing. The other thing that I must tell you is that, Jan and I, we are trained neurosurgeons. It's a long, arduous process, right? And I was just thinking, from high school, I think it took me 18 years before I finished my training. And talking about those time, I actually calculated that, and actually that's like more than 500 million seconds, So there's a lot of training that goes into this, from the interns, residents, and so forth. And I think we see a lot of things. I mean, I'm sure you do as well. All different kinds that can happen to the brain, how we can treat them, And we went through all of that, well trained, and I feel really confident that that's one of the things that actually helped me. When I walk in the operating room, I feel confident I can help this patient. And the other thing I think that really helped me is the teamwork that we have in the operating room, right? And the staff all together. Everyone has their own parts, they all work together. And I think that really makes us a really well-oiled machine.
So how many seconds was that?
It's about 600 million seconds.
I was wondering how many hours that turns into, because there's that famous saying that to become an expert at something, you have to do 10,000 hours. So that sounds like more than 10,000 hours to me, maybe 100,000 hours to cover all that. Dr. McIver, would you sort of echo those remarks, or what do you think?
Yeah, I agree with Dr. Park. Medicine is really an apprenticeship. So you have mentors that guide you through training. I can remember the first aneurysm I clipped, and I was scared to death, but the expert surgeon said, this is the way you do it, and taught me how to do it safely. This is really lifelong learning. Just today, believe it or not, in the operating room, I was preparing for a case, talking to the team, and they said, this is how Dr. Park does it. No. And it was something as simple as positioning a patient, and I had never done it that way. So I said, okay, let me try it. And it was learning that it can be done safely and efficiently this way. So it's really excellent mentors and commitment to lifelong learning. That's what enables you to do neurosurgery.
Now, in past programs, we've spoken to sports medicine physicians about concussion, CTE, chronic traumatic encephalopathy. Hopefully I'm pronouncing that correctly. What sort of brain issues and injuries are you addressing at the center?
Sure. We deal with conditions that affect the brain, such as brain tumors, maybe primary brain tumors that came from the brain itself, or even metastatic brain tumors that maybe came from the outside of the brain. Also, we deal with any kind of bleeding that's in the brain that's causing effects of the brain function, such as bleeding that's inside the brain itself or between the layer between the brain and the skull as well. We also deal with all type of other conditions, such as increase in pressure of the brain due to possible fluid buildup, such as hydrocephalus. We treat those conditions as well. And I think Dr. McIver can speak to some of his expertise on the brain conditions.
You know, I'm just thinking of clinic this past week, and as Dr. Park left off, there was a patient with suspected normal pressure hydrocephalus. And most people hear the term water on the brain, and what they're really referring to is these fluid-filled spaces in the brain that are enlarged in children. Surprisingly, the same condition or similar condition can occur in adults, where a person says, I can't walk as well, their spouse or partner says their memory isn't as good, and they have other issues, and it's actually due to fluid building up in these spaces, these chambers in the brain. So hydrocephalus in adults is one. Another two conditions I can think of are facial twitching. You may have seen a person whose eye just twitches and you sort of think, are they blinking at me? Are they winking at me? But there's something called hemifacial spasm, actually caused by a blood vessel pulsating against a nerve as it leaves the brainstem. A similar condition is facial pain caused by a blood vessel pushing on a nerve leaving the brainstem. That's called trigeminal neuralgia. And we treat those, interestingly, by making small pillows and cushioning that blood vessel, displacing it away from that nerve. So really fascinating things we can help patients with.
I'm wondering, do you have the ability to sort of turn your neurosurgeon's eye off, or every time you meet someone, you just can't help but be like assessing what their face is doing and so forth and thinking, this person really needs to come see me or whatever. Or how do you do that? Or do you not do that?
So it's very interesting, So whenever I see an infant or little babies, they say, oh, they're very cute. The first thing I do is I go and feel their soft spot. Right? And because of the pressure in the brain, sometimes soft spot can be really hard. So that's just first thing I do,
I agree. This is how we help people. This is sort of part of who we are at this point in life. So I don't think we are excessive in evaluating, but we do pay attention.
Mm-hmm. Now, I'm joking here that minimally invasive brain surgery sounds like an oxymoron, like jumbo shrimp. And somehow that doesn't seem to work. So how can minimally invasive surgery work? How is that even possible?
Sure. I think the whole idea of doing surgery is to be able to do achieve your objectives with a minimal collateral damage, right? So how do we do that? The way you do that is trying to get to the lesion or tumor in the most direct way possible, right? So before we had any kind of imaging, before, long time Egyptians, I guess, operated in the brain, just drilling holes here and there, trying to see where the tumor or brain bleeding was. And then after that, we started doing things like injecting air when you're doing a spinal tap, and we're trying to see which side the brain is shifted, or doing angiograms or looking at the blood vessels of the brain, so which area there's more blood supply rather than the other side to see whether there's any tumors there. With the advance of imaging, such as a CT scan or MRI, we had this wonderful way of actually looking inside the brain right now, right? To see where the tumor is, where all the other structures are and all that, right? That was all and good. But the problem is that imaging really doesn't let us know how to get there. But these days with the navigation, what do you see? You have a screen, right? There's destination, there's where you are, and there's a map of how to get there, right? And that's exactly what the navigation does for us, right?
One of the surgeries that I enjoy watching Dr. Park perform is this minimally invasive spine surgery. And the key or the beauty of minimally invasive techniques is that you limit disruption of supporting structures, you limit disruption of important circuitry. But you have to understand anatomy and you have to understand function. So I think a small incision is wonderful to show, but an excellent outcome is even better. And so you have to pair knowledge of anatomy with knowledge of function for true minimally invasive success.
Well, you mentioned spine surgery, which brings me to my next question, because you also do spine surgery, not just brain surgeries. Now, Dr. Park, in 2021, you began talking about your work with an interesting form of minimally invasive spinal fusion called Optilift. What is that?
Basically, when you do spine surgery, your goals are two. One is to actually decompression, which means that you're taking the pressure off the nerve. And the pressure can cause a lot of things, such as pain, weakness, numbness, and tingling, all of that, right? By removing the pressure, you're restoring those functions back, right? Second goal of the surgery is fusion, right? Where we actually fuse the two levels of multiple levels together. And the purpose of that is that you eliminate motion, right? When you eliminate motion, the micro movement, that it takes away the pain, especially from arthritic joints, right? So traditionally, the way we've been doing the spine surgery, it's been very destructive, right? So we make really big incisions in the middle line. We separate the muscles from the bone, in order to get to the bone to actually remove the pressure on the nerve, right? So this is what's called direct decompression, right? You're actually removing bone and ligaments and your anatomy, basically, in order to take the pressure off the nerve, right? So that's the, and then we put in screws and rods and so forth to make the fusion, right? So that's how the traditionally done. This Optilift or technique came along, and I said, wow, that is such a wonderful thing to do, because it's a technique that actually preserves all of your anatomy. So what it is basically you have a very small tube, right? And through that, we can remove the disc and putting this small spacer called OptiMesh. It's like a mesh with the holes in it. And once it's in there, we fill it with very hard cadaver bone. And using hydraulic pressure, you can actually increase disc height, right? When that happens, it also opens the hole where the nerves come out. So you increase what's called foraminal volume, and that's called what's called indirect decompression. Rather than removing all of the bone, you're increasing disc height, and they increase the hole where the nerves come out, and that's how we decompress the nerve, right? So it beautifully achieves the first function, which is a decompression. Second function it achieves is the fusion, because this mesh is porous, and there's a bone in it. Your own body will produce bone to go through it, and that achieves the fusion. Such a most elegant way of doing spine surgery, yeah.
Now, Dr. McIver, you've done some interesting work in the treatment of conditions like epilepsy and Parkinson's disease. Can you tell us about that?
We really enjoy helping people with a variety of conditions, and the two you mentioned can be very disabling. And these are chronic illnesses, and people go through decades of medication trials and efforts to improve the quality of life. So the implants that we can place can help or work with the medication to help restore function.
We'll take a break and return after these messages.
When I was younger, like in medical school, I had a bike, and one of my friends and I would go on bike rides, maybe 10 or 15 miles at the most. And then I got married, started a career, started a family. I really didn't bike at all. 2013, I started noticing, especially when I picked up something heavy or when I tried to run, I was getting pain shooting down the back of my legs.
Dan and I were actually co-residents at Shock Trauma. So we trained together in early 1990s. Before, he had about 7 millimeter spinal anesthesis, which moved with the flexion extension.
As an anesthesiologist, I have to push patients around on stretchers. If I couldn't do that without pain, then that significantly restricted what I could do at work.
One thing good about this procedure is actually when you put the cage in and you expand the disc space, you actually reduce the spinal anesthesis. So in general, because we are actually, really muscle and bone and ligaments and basically anatomy sparing procedure, the patient has pretty rapid recovery.
I was back at work in 3 weeks. That summer, I felt good enough that I started training for a century bike ride.
One time, I remember, pretty soon after we did surgery, maybe 3-4 week surgery, he came to my operating room and sort of sheepily smiling, and asking me, "Charlie, guess what I did?" I said, "What?" He goes, "I went on a bike road for like 100 miles last week." I said, "You did what?"
We've been doing that bike ride every year since. Dr. Park is an excellent surgeon. I've known him for a long time. He takes excellent care of his patients. He truly cares about his patients. Without this surgery, no, I don't think I would have tried to do a century bike ride.